Hi, everybody. It's Paul Cameron. So I guess we'll get started here. Dr. Lazarus is going to be speaking to us. As many of you know, he is CCTC MSICU's CSRU consultant. He's a clinician scientist and also our regional medical lead for Trillium Gift of Life Network. So he has graciously volunteered to talk about organ donation in a series of lectures that we're hoping he can deliver over the next couple of weeks or months. So as you can see, the title of today's talk, NDD and donor management, which are exciting new topics of recent innovation in the medical literature. So we're hoping Dr. Lazarus can entertain and educate us. So thank you. Go ahead.
Thanks for that introduction, Paul, and we'll get started. So just to remind everybody, we will be recording the first portion of this talk when the actual presentation, so then we can post it for everyone to view on our Facebook group for those who couldn't attend in live version of this talk. We'll hold off the questions to the end, please, so that we can tackle them all at once, and that way we don't have to record the Q&A parts, so that can be confidential for the purpose of this talk. And as Paul mentioned, this is going to be a series of several talks, and if you're interested in having this particular talk repeated down the road, or you have any other interesting topics that you want to discuss in organ donation, please let myself, Janet, or Megan know, and we'll be happy to do that for you. So my goal today is to sort of have to achieve the following four objectives, really: to review the principles and pathways for deceased organ donation, review specifically neurological determination of death, review a little bit of the donor management following NDD, and review the best practices in organ donation. And sort of in the future talks, we'll tackle donation after circulatory determination of death and donation after MAID, but for the purpose of today's talk, we'll focus on NDD. So the first thing I wanted to talk about are the principles and pathways for deceased organ donation. And I guess the first thing, the first principle the reason why we really do organ donation is that organ donation does save lives. And one organ donor can save up to 8 lives, and there are very few interventions or things that we engage in as intensivists, as ICU nurses, RTs, allied health, that can have such a profound impact in so many lives. So at times, we may not have such an opportunity that organ donation really provides us with an opportunity to save lives. So the second thing I wanted to mention is that organ donation is an integral component of high quality end-of-life care. And because of that integration of end-of-life care and organ donation, all patients should be provided with an opportunity to consider and incorporate organ donation in their end-of-life care. The third principle that underlies deceased organ donation is this concept of the dead donor rule. And essentially, the dead donor rule is a socio-ethical legal construct that tells us that organ recovery cannot be the cause of death of a patient. Or put in other ways, death determination must precede organ recovery. It must occur always before organ recovery happens. And this is the foundational, I guess, principle that currently deceased donation in Canada and in Ontario is based on. In terms of organ donation pathways, well, we have the really two pathways. It's either deceased organ donation or living donation. And within the deceased organ donation pathway, we have neurologic determination of death, so donation after neurologic determination of death, or donation after circulatory determination of death. And sort of donation after medical assistance in dying is under the umbrella of the DCD, and we will not be talking about that today. As I mentioned today, we will focus specifically on NDD pathway for organ donation. And the reason I wanted to start off these series of talks with NDD is, as you can see, NDD accounts for the greatest proportion of donors in Ontario. This is the annual number of donors in Ontario. It goes back to 2011. DCD was actually introduced in Ontario in 2006. I don't have that data available in the slide, but you can see that NDD makes about 2/3 of the available of the completed donations in Ontario. So when we think about pathways of NDD and DCD, you can see that because of the dead donor rule, this concept of death determination always precedes organ recovery, whether you go down the NDD process or the DCD process. And within an NDD process, what we have really here is patients who present with severe brain injury, and then we do the NDD assessment, which involves a thorough standardized clinical neurological examination, which remains the gold standard for neurologic determination of death. And in some cases where clinical neurological exam cannot be completed or is confounded by certain factors that cannot be resolved, we will do an ancillary test. And once death determination is done using NDD pathway, then we can proceed with consenting, workup, and organ recovery. But death determination has already occurred. In DCD process, the process is a little bit different, leading to death determination, and we will talk about it in future talks. So let's zoom in now into the neurologic determination of death. And when the first thing we should really do is define what NDD is. And neurologic determination of death is really an irreversible loss of the capacity for consciousness combined with irreversible loss of all brainstem functions, including the capacity to breathe. So in a patient who's brain dead, there is persistence of blood flow to organs, but the person has died. So the organs are perfused, but the person has died because their brain has died. So in terms of the medical criteria for NDD, we really have 5 plus the ancillary test, so 6 in total. And you can see them listed here. And so the first criteria that we have to meet for NDD is we have to have a proximal cause that is consistent with neurological death. We'll talk a little bit more about that. The second one is unresponsive coma. So you have to demonstrate that the patient is unresponsive to painful stimuli. There should be lack of confounding factors. There should be absence of all brainstem reflexes. And there should be absence of capacity for spontaneous breathing demonstrated by the apnea testing. So criterion first is extremely important in neurological death. And essentially what it tells us is that we should have a cause that would be in keeping with brain death. Almost always, this involves an increase in intracranial pressure, and the pathways to brain death are multiple. You can have traumatic brain injury or brain surgery. Patients may have anoxic injury following cardiac arrest or drowning. You can have vascular events like ischemic and hemorrhagic strokes, aneurysm ruptures, and severe forms of infections like meningitis and encephalitis. In some cases, other causes of increased ICP can be present, such as brain tumors leading to hydrocephalus and eventual brain death. But what is critical is if somebody is in coma, you cannot proceed with NDD until this criterion 1 is clearly established. So you have to identify why they ended up being in coma in the first place, and ideally demonstrate through imaging, perhaps, that there has been evidence of brain injury. So if somebody presents to the emergency room unresponsive, you should have a clinical history that is consistent with brain death. This patient has an outpatient cardiac arrest. They present to the hospital unresponsive. They have a CT scan that shows evidence of ischemic brain injury, and now they're in our ICU. And time has passed, and we think that they may be brain dead. So that story is very critical. There's no point doing the rest of NDD exam if the criteria 1 has not been met. For criterion 2, we have to demonstrate absence of all motor responses, excluding spinal reflexes. So there should be no motor response to verbal or painful stimuli, and we're doing central or peripheral painful stimuli usually. There should be no posturing, no shivering, no seizures, because seizures are a cortical event or brain event. So if the brain is dead, there should be no seizures. No facial or cranial nerve responses to stimulation of any part of the body, and no response to stimulation and cranial nerve distribution. And this is very important because if you think that patient is brain dead and they have absence of all motor responses, then they should not be on any sedation really, right? So if you think that patient is brain dead, sedation should be definitely off because they should not be experiencing any sensation. And so in terms of assessing motor responses to pain, in terms of central pain, these are the 4 ways you can assess central pain: applying supraorbital pressure, trapezius squeeze, team J pressure, which is what I prefer to do in my patients, and then sternal pressure. You can do all 4 just to convince yourself that there is no response to central pain. And peripheral pain assessment, you should be applying painful stimulus to all 4 limbs. And this just shows you that you should be applying the pressure to the edge of the finger, not directly over nail bed, because that's a more painful stimulus. The third criterion is we should have absence of confounding factors. And really, when we think about confounding factors, it's anything that may mimic brain death or interfere with the accurate completion of neurological assessment. So things that fall into this category is unresuscitated shock, hypothermia. So, and this is particularly relevant to patients who present with out of hospital cardiac arrest and then undergo hypothermia protocol. You can see that there is a modification for the temperature for younger patients, but generally speaking, if you're going to assess somebody for neurological determination of death, you have to make sure that they are warm, that the temperature is normal, greater than 34 degrees. Severe metabolic or endocrine disorders should be addressed. So the most important one for the purpose of brain death determination is low phosphate. So phosphate needs to be corrected, and high sodium. So sodium needs to be less than 160. Obviously, sugar should be normal because hypoglycemic patients can present and mimic brain death, and also evidence of any severe liver or renal failure may confound your interpretation of the neurologic determination of death exam. Patients with peripheral nerve or muscle dysfunction or neuromuscular blockades, again, turn off all, they should not be on sedation and certainly should not be on neuromuscular blockers, right? But if the patient has a history of severe nerve or muscle dysfunction, that should be identified to the assessing team and physicians, so everybody's aware. Clinically significant drug intoxications. That's a difficult one because certain drug intoxications like cocaine are unlikely to mimic brain death, whereas others, especially with synthetic opioids like fentanyl and can mimic essentially coma and brain death. So that establishing the clinical history is extremely important. And in some cases, when there is a potential for a significant drug intoxication or the history is unclear, we may need to proceed with an ancillary test after completion of all the clinical exam. Ocular trauma, artificial globe, and high cervical spinal cord injuries can also be confounders. The fourth criterion is absence of all brainstem reflexes. And so when we think about brainstem reflexes, pupils should be fixed and not responsive to light. There should be no corneal response, no Occulo-cephalic reflex, no vestibulo-ocular reflex, no spontaneous respirations, no cough, and no gag. And any brainstem activity would exclude the diagnosis of brain death. So in terms of how do we actually assess pupils, well, the pupils should be mid-size and fixed. Small pinpoint pupils suggest that there is unopposed parasympathetic stimulation to the eyes, and that can occur in things like locked-in syndrome, which would not be consistent with brain death. So you basically shine the light into each pupil and observe for change in size. If there's no change in size, then pupils are non-reactive. In terms of corneal response, and this is important for some medical students, residents, you have to actually stimulate the cornea, which is the color part of the eye. I've seen people try to assess corneal reflex by just scratching the sclera, the white part of the eye, and you're not going to elicit a response there because there's no innervation of that part of the eye. So if you really have to touch the with a little bit of a tissue or gauze, you have to touch the cornea to elicit response. For oculo-cephalic response, this is otherwise known as a doll's eyes. Obviously, the patient has to have a clear C-spine. The head of bed should be at 30 degrees, and then you do brisk rotations of the head left to right. And what you're looking there for is any eye movements. If there is no brainstem function, the eyes will be fixed. And as you turn the head, they will continue to move in the direction of the turning of the head. If the brainstem function is present, as you turn the head briskly, the eyes will try to stay central. So any movement of the eye during oculo-cephalic response rules out brain death. Vestibulo-ocular reflex, this is known as caloric testing. We have to ensure that the tympanic memory is intact, the head of bed at 30 degrees. And essentially what we do here is we institute 260 cc syringes of ice water into each auditory canal and observe the eyes for 1 minute. So normally what happens when you do this to an awake and conscious person like myself, if you were to infuse the cold water into the right ear here of a patient, you would see a slow deviation of eyes towards the cold stimulus. It's as if the patient is saying, what is that cold stimulus? And they start to look towards it. But the and that's the brainstem mediated response, the cortex will then force the eyes to stay central. And so what you will see is the slow response and fast. Anyways, the eyes will be moving. If the cortex is not working and the patient is comatose, but their brainstem is intact, you will still see a deviation of the eyes towards the cold stimulus, so towards the right. If there is no brainstem and no cortical function, the eyes will stay fixed. The fifth criterion is the apnea testing. The goal here is to assess for spontaneous respiratory efforts in response to hypercapnia and respiratory acidosis stimuli. There's really 4 methods available, and they practice all 4 methods are being practiced. As you know, at LHSC, we use the last method where we use carbogen, which is a mixture of CO2 and oxygen. And we connect this carbogen tank to the oxygen supply of the ventilator. And that really allows us to speed up the buildup of CO2 and to get patient hypercapnic and acidotic fairly quickly without the risk of hypoxia. In other methods, patients can basically get disconnected from the ventilator, and the oxygen is insufflated through the cannula into the endotracheal tube. But the downside of that method is that you lose the PEEP that's keeping our lungs inflated, and patients can get hypoxic pretty quickly before you're able to complete the apnea test. Also, the rate of rise of CO2 in all other 3 methods there is dependent on metabolic CO2 production by the patient, which is generally slow. Whereas with the carbogen tank, we can really get up the CO2 to high enough levels to assess if those levels are enough to stimulate breathing. And what we're looking here for is with any test, we would normalize blood gases and acquire baseline gases. And then we'll allow the CO2 to rise, and we will wait and observe for any respiratory efforts. And once the CO2 is greater than 60 millimeters mercury and at least 20 millimeters mercury above the baseline, the patient's baseline, and the pH is less than 7.28, they have met the criteria for an apnea testing. And if there is no respiratory effort, then that would be consistent with brain death. Any respiratory effort excludes brain death. Now, ancillary testing. So you would consider ancillary testing if you cannot complete any of the preceding criteria for any reason, or you have confounding factors that cannot be corrected. For example, if you have hypophosphatemia or hypernatremia, those can be corrected. So you don't really need an ancillary test. All you have to do is to correct those confounders, and then you can proceed with the clinical determination. However, if the patient has a missing eye or there's eye trauma, so you cannot assess corneal and pupillary reflexes, well, you sort of have to go with the ancillary test. The important point here is,
no, it's okay. It's
can you, whoever's, can you guys mute yourself, please, so that we don't, we'll get some feedback from someone else. So the important component here for ancillary testing is that the ancillary test does not replace the criteria 1 through 5. You still need to do as much of a clinical examination as can be completed, and then you go with an ancillary test. And that's why it's called an ancillary test. And if there is concerns, we generally suggest consultation with a donation support physician who are experts in organ donation and are available 24/7 on call in case there is a question about an ancillary test. In terms of accepted ancillary tests in Canada, there are really 4, and I've listed them in the general order of preference. So the nuclear scan of the brain is the preferred method amongst the donation physician experts and sort of donation experts in general, followed by CT angiogram, followed by 4-vessel angiography, and then MRA. 4-vessel angiography has fallen out of favor just because it's not very practical. CT angio is very accessible. The downside of CT angio sometimes is that people can get CT angios when they first get admitted, and then they have some residual contrast sitting around the brain. And so when they have a CT angio as an ancillary test, it's hard to interpret whether that contrast is new or is it the residual contrast from the previous scan, while that problem does not exist with the nuclear scan test. All ancillary tests are used to demonstrate absence of intracranial blood flow, and I just wanted to point out that TCD and EEG are not approved ancillary tests in Canada. So this is an example of what a CTA study, so CT angiogram, looks like. You can see on the left-hand side that there is no opacification of intracranial blood vessels, and this is sort of what we'll call the coronal slice looking at the patient. But you can see that extracranial blood vessels, there is a common chord, are opacifying here. So there's definitely blood flow in extracranial vessels, but there is no blood flow in intracranial vessels. This again is a nuclear brain perfusion study that would be consistent with neurological death. You can see uptake of radio nuclei dye in the lower portion of the head, but there is no uptake inside the brain, and this again would be consistent with the determination with the brain death diagnosis. So in terms of what do you need to do a NDD test, and there are really several requirements for NDD, is that you need 2 fully licensed physicians. So and the physicians should have independent licenses. Educational licenses do not qualify for NDD currently in Ontario and in Canada. You should be documenting NDD exam on a form provided by TGLN or on a specific hospital form, and at LHSC we have our own form for NDD determinations, so we use that form. In certain cases, we have to wait at least 24 hours before we do NDDs. So this applies to patients with primary hypoxic ischemic event. So patients post-cardiac arrest, drowning, choking, so on. There is a 24-hour waiting period. You cannot If the patient gets admitted at 1 p.m., you cannot be doing NDDs by 6 p.m. that day. You have to wait for at least 24 hours before proceeding with the NDDs. And there are certain modifications for pediatric patients that I will not go into, but they are a little bit different for patients under 1 month and 1 month to 1 year. In terms of the timing of death, so the legal time of death is at the time that the first declaration, including the apnea test, has been completed. In cases where an ancillary test is required following clinical testing and apnea testing, then the time of death is when both the first clinical exam and the ancillary test has been completed. And documentation of lack of brain blood flow is consistent with neurological death. So in other words, if you do clinical exam, it's the completion of the clinical exam at the time of death. If you do clinical exam plus an ancillary test, it's the timing of the ancillary test that has been reported as no flow is the timing of death. So now I want to go over a few pitfalls that we commonly hear about, and I'm one of the donor support physicians, so I provide consultation across the province, and sort of these are the common scenarios that we hear about. So the first one is confounders, and there are some confounders, like I said, that you cannot fix, but there are some confounders that we could for sure can fix. One of them is hypothermia. We had a few cases where NDDs were performed, but the patient was just too cold. So you have to make sure that the patient is rewarmed, their temperature is in normothermic range before you proceed with the exam. Correct the electrolytes. Make sure the patient is not hypernatremic or hypophosphatemic. And of course, hypernatremia can be corrected with things like free water, and hypophosphatemia was just replacement of phosphate. And make sure to turn off sedatives earlier. Okay, and this is probably the most common consultation we get. The clinical team proceeds with doing a NDD exam, and then we find out, and the exam is consistent with brain death. The death certificate is filled out. We got notified. We'll go and review the documentation, and what we find out is that the patient was on 10 milligrams of midazolam 2 hours prior to the death determination. So turn off sedatives early. You know, if you're thinking that this patient is going to have an NDD examination the following day, turn off sedation. The earlier the better, because if the patient is truly brain dead, they should not be experiencing any painful stimuli or any discomfort. And certainly avoid use of benzodiazepines, because most sedatives like hydromorphone or propofol will wear off pretty quickly in most patients, but the benzos, so midazolam infusions or even boluses, can last a long, long time. So turn off sedatives. I can't emphasize it. If there's one thing you take away from this, from this call, if you are a nurse at the bedside looking after a patient who the team is thinking about doing NDDs, remind the team, hey, we should probably turn off the sedatives. You guys okay with that? So yeah, remember that thing. So second issue is spinal reflexes. Spinal reflexes can be extremely disturbing to the those doing the NDD assessment, to the healthcare team at the bedside. But however, they have certain features that identify them as spinal reflex. And so the most important one is that spinal reflexes are reproducible in repeat stimulation. They tend to fatigue and then stop entirely when you repeat the stimulation. They typically are not reproducible if you change the location of the stimulus, and they're more common in lower extremities. That being said, if you haven't had any experience with spinal reflexes, it's best to consult experts, either organ tissue donation coordinators, and if needed, donor support physician on call. And with apnea testing, sometimes if the ventilator is not adjusted and the apnea test is being done on the ventilator, if the sensitivity hasn't been adjusted, then cardiac oscillation can auto-trigger the ventilator, and it may appear as if the patient is initiating these breaths, but it's really the cardiac oscillations. So I'd like to demonstrate a spinal reflex. I just want to let everybody know who's online. It's sensitive content, however, it's available in public domain, and I got this video from YouTube. So here's an example of a spinal reflex known as a Lazarus sign, and we'll go through this video together. So here you can see that the physician will turn the patient's head to the side, and you can see the flexion of the upper extremities. The physician will now try that again, and it doesn't happen. Now they apply a supraorbital painful stimulus, and this does not elicit the spinal reflex. They are now applying TMJ painful stimulus, does not elicit the spinal reflex. They're going to apply the sternal rub stimulus, does not elicit spinal reflex. And again, turning off the head, so reproducing the stimulus that led to that reflex will cause the patient to have another flexion response. And so this is an example of a spinal reflex. Another very common spinal reflex that we see is something called the triple flexion reflex, where there is a flexion of the hip, the knee, and the dorsiflexion of the foot and the extension of the big toe. And this is just shown in this picture. So that sort of sums up the neurologic termination of death. I would like to move now and briefly talk about the donor management of NDD donors. And I would like to acknowledge our own two physicians, Dr. Ian Ball and Dr. John Basmaji. As you can see, Dr. Ball was the lead author on the Canadian Clinical Practice Guidelines that were recently published last year in the Canadian Medical Association Journal, and he led a team of experts in organ donation and neurologic termination of death. And John Basmaji was also an author in these guidelines. And the key principle of donor management in NDD is to preserve the opportunity for successful donation and transplantation by maintaining all transplantable organs at an optimal level of function. And this really achieves two aims. First, it supports the donor autonomy by enabling and ensuring that the wish to donate is maintained. And it also improves outcomes in recipients. Somebody's audio is not muted. Can you please mute your audio? I'm not sure. Somebody's joined, and maybe I'll just mute here. Okay. So, I welcome you all to read these guidelines. They're very detailed, and there's a lot of work that's gone into creating these, but I'm just going to summarize at a very high level. And if you were to look at it, if I was to summarize in one line, essentially what you're trying to do in donor management is manage the donor just like you would do a critically ill patient, okay? So what does that mean practically? Well, we continue our usual hemodynamic and respiratory support. We aim for a mean arterial pressure target of 65 or greater and urine output of at least 0.5 mL per kilogram per hour. If the patient requires vasoactive agents to support their blood pressure, we use norepinephrine and vasopressin. The recommendation is to avoid dopamine at any dosages in these cases and use crystalloids primarily for fluid resuscitation. In terms of protecting the lungs, the recommendation is to use the tidal volume of 6 to 8 mL per kilo of predicted body weight, PEEP of 8 to 10. Use CPAP for apnea testing, and then obviously use a closed circuit. Avoiding and correcting hypernatremia can improve outcomes in liver grafts. And so the way that patients get hypernatremic is NDD patients, because their brain has died, no longer produce antidiuretic hormone. And so they develop a form of central diabetes insipidus. So they start producing large volumes of dilute urine. And so the way we manage diabetes insipidus in our unit, we use a vasopressin infusion, and that's in our order sets. Or we can also use intermittent DDAVP boluses, but generally speaking, we use vasopressin infusion. If there is a water deficit that the patient's hypernatremic, corrected with using free water, or if needed, D5W, and then you could resuscitate the patient if they're hypovolemic. In terms of hormonal therapies, so if the patient requires vasopressor support, then there is a recommendation to use IV corticosteroids, just like what we'd use for septic shock. So this is hydrocortisone dosing. Now, in terms of thyroid hormone was thought to improve cardiac function in potential heart donors. The recommendation currently is not to give it routinely, but if the transplant team, if the heart team requests thyroid hormone to be administered, we should facilitate that. And the same goes for lung donors. So there's no recommendation with respect to high-dose corticosteroids, but if the lung team requests high-dose corticosteroids, we should be administering it. Now, the very, I guess, a big addition to this guideline was temperature management. And so if the donor has kidney donation potential, so they're still being considered for kidney donation, we should be aiming for a mild form of hypothermia, targeting a temperature of 34 to 35. Again, this is after NDDs have been completed and death determination has occurred. Targeting hypothermia in these patients has been shown to reduce delayed graft function in kidneys. However, if the patient has no potential for kidney donation, then we should aim for normothermia. I should emphasize here that this recommendation is solely for NDD donors. So for donors who are undergoing neurological determination of death, so they have no brain function and therefore no way to perceive hypothermia and be uncomfortable as a result of that. We do not use hypothermia for kidney grafts in DCD donors. Okay, so this is only limited to NDD donors. On that note, I'd like to summarize my talk with sort of a quick summary and highlight some of the best practices that we should all follow. So as I mentioned during my talk, and hopefully conveyed to you, that organ donation does save life and should be an integral part of high quality end of life care. There's two pathways for a deceased organ donation, both of which ensure that death determination precedes organ recovery, and this is known as the dead donor rule. Today we talked about NDD, and in future talks we will talk about DCD. But with respect to NDD, we've reviewed the 5 criteria plus the ancillary test. And in terms of 5 criteria, we need to complete an NDD. We need a proximal cause, evidence of unresponsive coma, lack of confounders, absence of brainstem reflexes, and an apnea test. And in cases where we cannot complete one of those 5 criteria, or there are confounders that cannot be resolved, we can proceed with an ancillary test. In terms of best practices, so there's really 3 things I wanted to touch on here. So the first one is I recommend that TGLN is notified earlier. And what do I mean by that? So if there is a plan to have a, to have a meeting with the family for proposal of withdrawal of life support measures, we should be notifying TGLN early. And you can see here that the longer the time on the x-axis, there's time from notification from NDD to referral. And the longer time that we have as an organization, the higher rates of approaches for donation. The second thing I would like to emphasize is that we should aim for a collaborative approach that is led by experienced Trillium Gift of Life coordinators. And we're lucky to have 2 experienced coordinators that are with us at all times. So Janet Taylor and Megan Willer are both on the line today. And I'd just like to highlight that donation approach is an expert conversation. It's not a question, and it's never merely a mention. And I will tell you my personal experience, because when I started with Trillium, I was actually lucky enough to have an opportunity to participate in some of the simulation training that our coordinators go through in terms of approaching families. And I've done many end-of-life conversations or meetings with families to propose withdrawal of life support measures. And I can tell you that it was an extremely difficult discussion to lead in those simulation scenarios that we've had during training in Toronto. And one thing I took away from that is that even though I work in organ donation, I would certainly defer to organ tissue donation coordinators, because they just have way more experience and they have dedicated training on how to do this well. And so there are a few reasons, additional reasons for why we should be deferring the approach for donation to our coordinators. Well, first of all, they have information about whether the patient had a registered donor consent. And oftentimes that helps tremendously when approaching families. You can imagine if a patient had a prior registered donation consent because they filled out that they wanted to be an organ donor when they got their driving license, that going into discussion with that family, the conversation changes from exploring organ donation to just saying, look, your loved one explicitly wished to be an organ donor at the end of their life, and we're here to help you honor that wish, right? So it's a lot of it, it's a much easier conversation. They also have up-to-date information on suitability of a particular patient for to be an organ or a tissue donor, and that changes all the time. So the criteria for whether the patient is eligible in terms of their age, comorbidities, that changes as the transplant science evolves. So instead of us keeping up to date with that, they kept up to date with this information, and they have all the relevant info. They also have 3 times a year sim sessions that as I mentioned, I was lucky to participate in one of them, but I have 3 times a year that have simulation sessions in Toronto, and they all complete at least 60 approaches per year. I can tell you that if you do 60 central lines per year, you're probably an expert in central lines. Well, OTDCs do 60 approaches per year, so they're experts in organ donation. And the most important thing here is we're all busy. Especially physicians. We have a whole unit to look after. We have residents to teach, fellows to supervise. The coordinators have time to spend with families, and because it's a process, the consent for donation or consideration of incorporation of donation into end-of-life care, they have the time and the information to spend with the family. And so that frees you up to do other things. And all of this translates into this metric. You can see that when organ consent, so when families are approached for consent for organ donation, coordinators from TGLN are much more successful in obtaining consent for donation than when hospital staff approach or mention organ donation to families. And the last thing I was going to say, that donor management is key to preserving donation opportunity. And so the last thing I want to say is that we're here to help. This is you can see the pictures of all donor support physicians. There are 7 of us in the province, and we take call for a week at a time. And if you ever have any questions about donation, please reach out to me, to coordinators, Jen and Megan, and know that if you have a question about an active case at any point in time, you can reach to TGLN and ask to speak to a donation support physician to discuss any concern or challenge that you may be facing. And there's some references here that you may want to access later. And on this note, I'd like to stop and take any questions. Thank you.